Well, in steroid-naive patients, the NICE guidelines suggest a FeNO of more than 40 parts per billion. The ATS guidelines suggest a FeNO of 50 parts per billion. I mean, at the end of the day, it's a bit of an arbitrary number. But a FeNO on its own, that will tell you whether the patient, a raised FeNO will tell you whether the patient is likely to have type 2 inflammation, Th2 inflammation, which responds to inhaled corticosteroids. And FeNO is exquisitely sensitive to inhaled corticosteroids in asthmatic patients with type 2 inflammation. And we've actually published data in the chest, which was cheesily called the phenotype trial, which you can look up. William Anderson was the first author, showing that in such patients with a raised FeNO, these were steroid naive patients, that the FeNO drops by about 50% within the first 48 to 72 hours. And interestingly, in that study, there was a clinically relevant improvement in the asthma control questionnaire score, which exceeded the minimal clinical important difference of 0.5, which accompanied the reduction in FeNO. So on its own, it will give you a very strong indication of the likelihood that the patient's got type 2 inflammation, which will respond to inhaled corticosteroid therapy. In terms of predicting exacerbations, then you have to take into account not just the FeNO, but the blood eosinophil count as well, what I call the type 2 pivot, which is the balance between FeNO and eosinophils together, which is very highly predictive of exacerbations, together with airway caliber measured with spirometry or oscillometry, and of course asthma control measured with the asthma control questionnaire. So you have to take all of those together. But in terms of predicting an inhaled corticosteroid response, then FeNO and blood eosinophils are equally predictive. I mean, the beauty, of course, about FeNO is that, as you know, it's a point of care test. You get it right at the point of care when the patient's sitting with you in the room, so you can make a very accurate prediction, whereas you usually have to wait for the eosinophils to come back, then the patient's already gone and left, and you have to then communicate that to the patient either directly or via primary care. So in that regard, it's really the only point of care test for assessing type 2 inflammation in predicting a treatment response. So that's mild to moderate asthma.